Okay, so today we'll start with basics, means principles of intravascular ultrasound. And so we'll learn about intravascular ultrasound principles and what determines IVUS image quality, and learn about two types of imaging transducers. Imaging transducers I'll keep it for later, but we'll have a discussion more about ultrasound principles as well as IVUS image quality. So what is ultrasound? So as you can see in the picture itself, it shows that 1 megahertz of frequency has a good penetration of the ultrasound through the skin, and whereas a 3 megahertz frequency ultrasound has a very less depth as compared to the 1 megahertz frequency. So what it signifies is that the frequency of ultrasound is inversely proportional to the depth of image. So higher the frequency is lower the depth, and lower the frequency, higher is the depth. So that is very important because when we are trying to take ultrasound images, whether the image quality or the depth of image is important, it is determined by this very factor. And also, uh, the frequency of ultrasound is directly proportional to the axial resolution or the image quality. So higher is the frequency, higher is the axial resolution, and you get a good image quality. So our ultrasound IVUS catheter has an ultrasound transducer at one side. It is not mounted throughout the catheter. So it is as it is. Just a moment, I'll just show my pointer. So as it is shown in the picture, it is there at the near the 20 mm from the catheter tip. Okay, you have your second marker. So that is your ultrasound transducer, and it fires and rotates at 1800 RPMs to generate an IVUS image. Second, other things about the IVUS catheter is that from the tip we have our first radio opaque marker, which is to signify the distal tip, and it is 5 mm from the tip. And the distance between the two markers, that is the distal marker and the proximal marker, is 15 mm. So this is a small video which shows how the image is acquired and displayed on the screen. So I'll just repeat it once more after it gets completed. So in the center, you can see the catheter. Then you can see the vessel lumen with blood speckles. This is the intimal leading edge. And then we have the medial border, and rest is adventitia or the adventitial border. So same can be seen over here on the right hand side picture also. We can see lumen with intimal border, then medial border or media, and then adventitia. So these are the three layers which we can clearly identify in our IVUS image. I'll just play this just a moment. Play this video again. Angels, I'll take the
We
next
can,
slide.
yeah, we can go ahead.
Yeah. So this is a image quality example as I had already described. Lower the megahertz, we get axial resolution which is greater than 100 micron, which doesn't provide you a very clear pixel to pixel differentiation in the image. But as we increase the megahertz, that is in 40 megahertz or in 60 megahertz. So in 40 megahertz, it is 38 micrometers, and in 60 megahertz, it is 22 micrometers. So the image quality is drastically increased, but yeah, the depth is a bit compromised when we are using a higher megahertz frequency.
Just
Are
one
you?
point, just one
Yeah.
point to clarify here. Like as he rightly mentioned that as frequency increases, the penetration depth decreases. So it is not like that the 40 megahertz will have a better penetration depth compared to our opticross 60 megahertz. But in our opticross 60 megahertz, the penetration depth is same as that of opticross 40 megahertz. The reason behind that, the transducer technology what is incorporated into opticross HD, that is 60 megahertz, is it's a wideband transducer technology. So what exactly that wideband transducer technology does, that keep emitting the sound waves which range between 40 to 60 megahertz continuously. So with that technology, we can ensure to have the penetration depth equivalent to 40 megahertz catheter and the axial resolution which is much better than the 40 megahertz because of the wide band which is produced by the 60 megahertz. So the sound waves which are emitted will be ranging between 40 to 60 megahertz continuously. So you get a much clearer picture with the same penetration depth. So that is a patented technology with Boston Scientific. Sorry to interfere in that. Continue, Sushant. Am I
Yes,
clear
yes.
Vishal
with
sir,
you?
one doubt. Uh,
Yes, Arshil sir.
Hello.
Yes,
Yeah.
Yeah,
Arshil sir.
in books we read the IVUS. There are two systems. One is solid state dynamic aperture, and another is mechanical scanning. So which one
Yes.
do we use?
So the solid stage, or it is also called as a phased array technology. So phased
Mm-hmm.
array is the one which is seen on the left hand side in this picture. Okay,
Okay.
the Eagle Eye Platinum 20 megahertz is a solid state, or it is a phased array technology. So the one which we are using is a mechanical transducer, or it is also called as a rotating transducer technology. So as
Okay.
Sushant go on the next page, I think he will be able to show you the difference between this both the technologies.
Yeah.
All right. All right. Okay.
Yeah.
So this is some of the analogies which we have created where we can show that it is just an example where transducer is equivalent to Netflix. MDU5 is the medium or the TV, and signal processing and image processing is the software on the HD TV. The software which we visualize on our Polaris iLab. So transducer which captures the image, MD5 is the medium to take it to the acquisition PC, and acquisition PC is then provided to imaging PC to display it directly on the screen.
So basically, this slide talks about the image quality, or I would say the clarity of the image quality. It not only depends on the what frequency of catheter you are using, but there are other components which are also involved in defining the much superior image quality. So that is nothing but the transducer design, the hardware, or the graphics which is involved in the hardware, and the signal and image processing unit, the platform on which the entire system is working. So all these things also contribute to the a better image quality. So tomorrow it should not like be perceived like if any other company is offering you a 60 megahertz, that means you will get the same 60 megahertz quality what Boston Scientific is offering you. So within 60 megahertz also there would be difference on the basis of these three factors. Am I clear?
Okay. Okay.
So these are the two different catheters which we can see. So the first one is the rotating mechanical IVUS catheter, and the next one is the solid state IVUS catheter, wherein a stack of transducers are placed one over the other in circular form, which fires at the same time to generate an image. Whereas in our rotating element, it rotates at a speed of 1800 RPM to generate the image. And as you can see, ours is the transducer goes on a monorail, and the length of monorail is 1.6 centimeter, whereas the solid state it passes through the guide wire directly.
So we have a single element which is there in the transducer. So it's a single element which keep emitting the sound waves while it is rotating in 360-degree by the drive shaft. Do you see the drive shaft behind it? So this drive shaft help it to spin it. Okay. Just like the rota burr, you have seen the rota burr, how the rota burr tip is rotated by the drive shaft. Same way, this
Ye-
drive shaft rotate the single element of the transducer here, and this element keep firing the sound waves when it is rotating. Clear? So what is the advantage of a mechanical transducer over a solid state transducer? The advantage of mechanical transducer is there is no blind spot in the entire cross-section image of the IVUS. Whereas in a solid state transducer, there is a 6 degree of blind spot between the two elements. So that 6 degree of blind spot is corrected by the computer automatically. So that's the reason the image quality, if you compare with that of the solid state and the mechanical transducer, is way different.
I have some questions.
Yeah, yeah.
Yes, Kunal sir.
Okay, first is out of cardiology, like the engineering of this rotating element, mechanical. The drive
Mhm.
shaft is completely connected up to the device which we hook in into the sterile drip. It is such a long
Yes.
drive shaft.
Yes.
Okay.
Yes, yes, yes.
Uh,
And many of the time you must be seeing that the catheter gets kinked and you won't be able to acquire any image. So what happens, this drive shaft, which is a fiber optic cable, okay, it's not as sturdy as that of a rotor drive shaft. Rotor drive shaft is a different, it's a more of a mechanical drive shaft. But this drive shaft is carrying signals inside it. So it has got a fiber optic cables which actually carry the signals received from the vessel. So whenever the sound waves are emitted, whatever echo is coming back will be captured at the tip of this element. Okay, and this captured echo which is there will be sent back through this fiber optic cable to the system. So this drive shaft is very, very crucial. And if any minor kink happen in the catheter, you may lose the image.
yeah, now that it's clear why is it so. And the
Yeah.
second question,
Hmm.
if mechanical IVUS are so great, what is the relevance of solid state IVUS in today's day?
Yeah, so in fact, the competition also has realized that solid state transducer are not as great as that of a mechanical transducer technology in acquiring image. So if you see the recent launch of Philips has recently launched a 45 megahertz catheter also, means few years back. And they have also now shifted from a solid state transducer to a mechanical transducer technology. So they have incorporated a mechanical transducer technology in their 45 megahertz catheter. This one, what is there is their 20 megahertz catheter, which was the initial one. So they have also realized the shortcomings of this catheter.
Sir, how is it that solid state is better in OCT in CTO? They mentioned
So
that solid state catheter are better in managing CTO.
yeah, so there was a concept earlier that the shorter the distance between the tip and the transducer. So can you see the entry tip and the transducer distance? Okay.
Yes.
So this distance is very, very critical when it comes to managing a CTO case, because in CTO you want to park the IVUS catheter in the proximal side branch. And if the
Mhm.
side branch is very small caliber branch, Then the landing zone needed to park your IVUS catheter in such a way that your transducer comes at the ostium of that side branch, so that you can visualize the CTO cap and you can start
Yes.
puncturing the CTO
Puncture.
cap with
Yes.
the CTO wire. Okay.
Yes. Yes.
So
Okay.
yeah, so if you compare this, the distance between the tip to transducer, it
Is
was
less in solid. Yes.
shorter than our previous generation IVUS catheter. So previous to Opticross, we had a Atlantis SR Pro catheter. So that catheter was having a 28 of tip to transducer distance. But now in the
Okay.
new system, the tip to transducer distance is 20 So same as that of a solid state. So the landing zone, or I would say the parking area needed in the side branch, is same with the mechanical as well as a solid state. But now, since this most of the books are already printed long back, they have continued with that I would say principle that for a CTO, you actually solid state is much better than the mechanical transducer.
And
But that is not
okay.
so nowadays with the launch of OptiCross. And one more thing, actually speaking, if you really want to have a true forward-looking catheter, in today's context, no company in India has got a forward-looking IVUS catheter. Forward means you can see the image beyond the catheter, just like a
Okay.
torch. If
Yes,
you
sir.
are,
So it's the, yes.
are you getting it?
Image.
Like if you,
Yes. Yes.
You,
It is like a toss. Agreed. For
yeah,
CTO,
Tushar,
that
so
is required. Yeah.
yeah,
you just answered one of my query. I was just gonna ask you: is there a IVUS which shoots ultrasonic waves
From,
forwards, not rotationally in one plane, but like a torch or a bullet or a shotgun firing? No,
yeah.
something
So I
like
think Terumo has got that forward-looking IVUS catheter. That is the only company which has got that forward-looking IVUS catheter.
okay.
Yeah.
so. That will be very beneficial for a CTO. No.
Yes.
Yes,
Yes.
so without even parking the catheter in the side branch, you can park it on the CTO wire, and the CTO wire is keep poking in the CTO cap, and you can see the forward-looking image.
All right. All right.
So in this case, either of these catheters, solid state or the short monorail, you have to take this catheter on another wire, which will be
Right.
parked into the side branch proximal to the CTO cap, and you will ensure that the transducer will come at the ostium of that side branch, so that keeping the transducer live in rotating situation in that segment, you can start poking your CTO wire into the CTO cap, and you can visualize on the IVUS screen whether the puncture is happening within the true segment or it is going into the subintimal plane. That much you can very well assess.
Thank you so much.
Okay.
Okay.
Yeah.
And there's also one more, like non-uniform rotational distortion is also more in mechanical than solid.
Yes, so we will come to those aspects of a discussion. Why nerd is there with the mechanical and not with solid state? So every technology has got its pros and cons, but ultimately, what is the basic objective for which you are utilizing the technology? If that is not met, like for example,
Agree.
if you are having a smartphone, and if any smartphone has got a very beautiful HD camera, okay, for doing a photography, but its signal reception is not good, so you cannot hear the voice clearly. Then basically you are buying a smartphone for talking to someone, right?
Hmm. Yes.
And
Yes.
you have SLR cameras and everything for photography. So if your purpose of that particular device is receiving a clear signal or clear voice whom you are talking to, if that is not there and rest of the features are better, then I think that technology won't fulfill the purpose. So similarly, in both these technologies, there are some pros and cons, but what is more important, your basic objective is to acquire a better image, is fulfilled with the mechanical transducer catheter.
All right. All right. So we can proceed. Yes.
Yeah.
Yes. So, as rightly said by Vrushal, in our OptiCross catheter, which has a mechanical IVUS catheter, the transducer is placed in one point and then it rotates in an angle so that there is no miss of any image. But in the stacked array or solid state IVUS catheters, the IVUS transducers are stacked one over the other in a circular form like this, for an example, and it shoots or fires at the same time to give an image. So this is
One
one.
more, just
Yeah.
go on the previous slide. One more point, just to highlight. So
Yes.
basically, if you look into this image, this is a cross-sectional image shown of the catheter. So in case of a phased array technology, the guide wire goes from inside of the core of the catheter. So it's a OTW kind of a system, whereas the transducer is directly in contact with the blood in the lumen. Okay. So at times the vibrations of this transducer directly goes into the artery and arteries go into spasm. So most of the time you must have seen when you are using a phase direct catheter, you see the issue of a spasm happening because the transducer's vibrations are directly in touch with the blood and the artery. Whereas in case of the mechanical transducer technology, the transducer is inside the protective sheath here, this sleeve, what you see here, and the gap between the imaging core and the sheath is filled with the saline. That is a heparinized saline what we flush. So this
Yes.
saline acts as a medium to travel the sound waves from this transducer to the artery. Okay, if the medium is having any kind of a bubble entrapment in this medium, then you won't get a better image. So whenever you get a dark image, that is because of the bubble entrapment between this imaging core and the sheath. So this flush also acts as a lubricant. So it keep lubricating the surface. It minimizes the friction between the rotating imaging core and the sheath. So whenever you get to see the nerd happening, no, nerd happens mainly because of the resistance which this rotating imaging core gets. If this is not rotating smoothly and if it gets stuck at one particular point, then that one particular point image will be blurred or it may not be a readable image. So this mainly happens because of the poor flush, or even if there is a if any tortuous anatomy is there, and if calcium nodule which is denting on one particular angle. Suppose at 3 o'clock there is a nodular calcium which is pinching in the sheath, and it is restricting the rotation of this imaging core smoothly. Then at that particular angle, the IVUS image will be blurred. So how to resolve that issue of NURD, that is non-uniform rotational distortion? The name itself tells you about the meaning of the problem. NURD, that is non-uniform rotational distortion, means this rotating imaging core is not rotating smoothly, and because of that, wherever it is getting resistance to rotate smoothly, that particular angle image in IVUS will be a blurred image or a hazy image. Rest of the image will be clear. So to take care of that kind of a troubleshoot, you simply need to readjust the IVUS catheter. You need to just push and pull out the IVUS catheter so that the portion of the proximal tortuous segment or the calcium nodule in that segment, which is pinching the IVUS catheter, will be managed. Like due to the wire bias or due to other reasons, that particular segment may be getting pinched, or maybe because of a poor flush in the catheter, that particular segment of the rotating core is brushing with the sheath at that particular point. So if flush is adequate, everything is perfect, then nerd can be also resolved. It is not like that nerd cannot be resolved. Okay. And the guide wire goes from the outside of the IVUS catheter in mechanical transducer. So throughout the long view of the IVUS image, you get to see a guide wire artifact. Clear?
Okay.
Any questions on this part? Because this is very, very important part. Like if you understand this entire, the basic difference between these, both the catheters, no, doing imaging and addressing troubleshoot will be very, very easy for you. Means the moment you see any troubleshoot, you can correlate this is happening because of this particular reason, right?
Can we
Okay.
come a slide back?
Yeah.
Yeah. So one more thing here. In a solid state catheter, can you see the cables, the positive, negative, and the neutral cables? These cables run parallel. So this catheter is more of an imbalanced catheter. Okay. These are the cables which are running across the, and since it's a over the wire catheter, it is very difficult or bulky also to deliver. And there is a 6 degree of blind spot in each of the solid state transducer which are attached.
Okay.
Rushal sir, so
Yes.
seeing the differences, it seems to me that solid state IVUS was the first IVUS ever made. And from there, all the inspiration has come into improving the solid state IVUS. Correct me if I'm wrong.
No, it's not like that. Solid state was designed by Volcano. So see, when imaging was on there was a revolution and there was a need for doing something intracoronary. So there are companies which were working on their own technologies. So simultaneously, Boston Scientific was working on a kind of a mechanical rotating transducer technology, whereas Volcano was working on a solid state transducer technology. So each of them had their own, I would say, objective to meet for that particular product. So, as rightly said, Boston Scientific was having the thought process of making a imaging catheter which will be much more deliverable, as well as the image quality should be of highest grade. There should not be any kind of a compromise or error in the image quality. However, there could be some other drawbacks, like you need to flush the catheter. Unlike in phased array, you need not to flush the catheter. You can straight away take and advance the catheter inside the coronary. But you tell me actually, flushing the catheter, how much time it takes?
Not much.
So,
Yes.
so whenever any product goes under the R&D, the R&D team also thinks on those lines. Like, okay, if I am going to develop this product, and if there is one more additional step need to be done, but after doing that step, if the image quality will be of the highest grade, then what is wrong in doing that additional step? Whereas some people of the opinion that, okay, if I'm reducing that one step, then let me highlight that as the one step less in prepping up our device, and that will help us to promote the product. But at the end of the day, if you waste time in flushing the catheter, but if you don't waste time in analyzing the image, if the image is so clear to your eyes that your diagnosis will be far quicker and perfect, you need not to keep reading the image again and again, then which one will you prefer? So I'm not saying just because the image quality with our Boston IVUS catheter is better. I'm just talking on a mechanical and a phased array technologies.
Agreed.
Okay, so that's how these modalities are evolving. And if solid state transducer would have been that much promising, in fact, all future technologies would be uh, move towards solid state transducer rather than solid state companies moving into the mechanical state.
Mechanical detector. Yes.
Yeah. So ultimately, the technology is evolving. So you never know. Tomorrow you will get something better than this also. So we are not claiming we are the best. What we are claiming in today's context, whatever the imaging modality which is available, the best image quality can be acquired with the help of these HD IVUS catheters. So tomorrow there may be something which will come completely out of the box with some different innovative technology. Maybe a wire with the having a IVUS transducer technology. Okay.
Okay. Okay.
So I hope this basic first session on the basics of IVUS imaging is clear to you.
Yes, sir.
So with that, if time permits, we have still 15 to 15
Vishal, I
minutes
was
more.
thinking of showing them a video on IVUS catheter preparation.
Okay, okay.
So then after that we can, if time permits, then we can go for image quality. Is it just a moment. I'll just try and see if my just check if the sound is coming of the.
No, sound is not coming. So
Not coming. I'll just check. I'll just.
you click yes while you connect
The
for this
MDU
one.
file.
Yeah,
Is
now
it?
we can.
Yeah. Just a moment. I'll make it full screen and then show it. Kunal sir, Arshil sir, if there are any doubts, you just ask me to pause it, then we can clarify it.
Sure.
To bag the MDU5 Plus motor drive, one sterile field operator and one non-sterile field operator are required. The MDU5 Plus sterile bag is located within the imaging catheter box and should be placed on the sterile field. The sterile field operator will unfold the bag with the faceplate on one end and the Insert Here sticker on the other. Ensure the This Side Up sticker is facing the ceiling. The sterile field operator will place hands into the innermost folds of the bag and open the bag for the motor drive to be inserted. The non-sterile field operator will place the motor drive into the opening of the bag with the faceplate pointed up.
So here I just wanted to pause it and just show it to you once again. So whenever we are bagging the MDU, so usually what happens, the non-sterile operator, it just hands over the MDU5 to the sterile operator and leaves it and just pulls the plastic bag behind. But what we can do to make it quicker and easier, so it will take hardly 10 seconds to bag the MDU as well as connect the connector properly. You won't have to play around while doing that. I'll just
Operator will place the motor
repeat it
drive
again.
into the opening of the bag with the faceplate pointed up.
So in this way, the non-sterile operator holds the MDU and the sterile operator tries to push the plastic behind till the point where the connector comes in contact and he attaches the connector. After that, only the non-sterile operator releases it or pulls the plastic behind. So these are some of
The
the
sterile
hygienes
field
which we can
operator will
follow.
attach the faceplate to the motor drive unit to ensure no bag material is caught between the motor drive and the faceplate. Working together, the operators will unfold the bag and extend to its full length. It is important to flush the imaging catheter properly to ensure the highest quality IVUS image output.
So these are the things which are available in the IVUS catheter packet. One is a 3 cc syringe. Another one is a 10 cc syringe, a 10 centimeter extension, a three-way cord, three-way wall, as well as the IVUS catheter. And to prepare the IVUS catheter, we require a heparinized saline. So the combination is such: in 200 ml of saline, we put 1000 international unit of heparin.
Image output. Fill the 3 cc and 10 cc syringes with heparinized saline and ensure.
So in this step also, you can appreciate one more thing. When the operator is trying to fill the saline in the syringe, he is trying to push it once or twice so that if there is any vacuum or any air which is trapped inside the syringe can also be released, and the syringe which is filled up is completely air free, so that we don't have any air which is going inside the catheter.
all
No.
air is expelled.
Just a moment.
Yes.
Yeah, the
I would
reason
like,
of the reason of
yeah,
doing it 2-3 times is that the new syringes are having some kind of a lubrication inside. Okay, so the wall of the syringe, if you fill it up for the first time, no, the entire wall of the syringe will have the micro bubbles stuck on the wall, internal wall of the syringe. So to ensure that there should not be any kind of a micro bubbles attached to the wall of the syringe, they do it 2-3 times. So whatever the lubrication related layer is there will be completely taken off, and the micro bubbles will not stuck on the wall of the inner wall of the syringe. So if you can see the second syringe also how they fill it up, you will realize that. And that is really that is a fact. Even in your routine practice, you try doing it, you fill up the syringe for the first time, you will see a lot of micro bubbles stuck on the inner wall of the syringe. And if you do 2-3 times rinsing of the syringe and third time when you fill it up, there will be no micro bubbles.
Okay.
Right.
Also, it is very detailed that the 3 cc is a glass syringe, no?
Yeah, it is
Yeah,
a
it's
fiberglass syringe.
yeah, it's a fiberglass syringe.
Yeah, it is a glass syringe. It prevents air bubbles at all from coming.
Yes, I'll start the video again.
Connect the filled 10 cc syringe to the 12 o'clock position on the stopcock. Perform a wet-to-wet connection with the filled 3 cc syringe to the 3 o'clock position.
So this step is also very important. It is similar to what operators do when they are preparing the balloon for to connect it with the inflation device. So usually they try to put some contrast inside, and then after that they put some droplets and then connect it so that there is no air entrapment and it is completely air free.
Of the stopcock. Connect the extension tubing to the 9 o'clock position of the stopcock and expel all air by flushing with the 3 cc syringe. Fully open the telescope on the imaging catheter by pulling the telescope from the hub of the catheter and attach the extension.
So here you can see one red color marker, which is the hub of the telescope, and the operator is removing the catheter out from it, and you can see some white dots. They are 1 centimeter apart from each other. Okay, and there are 15 dots. So when you don't have a automatic pullback available, and if you want to do a manual pullback, so during that time this dots will be you'll be able to mark the length by you viewing the dots. Is there any input from Vrushal? Do you want to have any input on this?
So basically, what this dotted line dots which are there, this portion of the catheter is called as a telescope. So you must have seen those old era telescopes where from the binocular you pull out the telescope out and then you focus better. So this is just like that. The telescope is here. Okay. So this telescope has got this marking at the gap of 1 centimeter apart. Okay. So each dot is 1 centimeter apart, and total 15 dots will be there. So total length of this is 150 mm. But in automatic pullback, the maximum pullback happens only for 100 mm. But if you are doing a manual pullback, you need to hold with your left hand on this red marker. Okay. And this side, the right hand side, the connection will be there on the MDU. Okay. This portion will be connected to MDU. So your right hand will hold the MDU and you will just pull your right hand slowly when imaging is on and manual recording is on. And while pulling it back, you will keep watching under fluoro on the movement of your transducer in the screen. The moment your transducer comes at the proximal healthy landing zone, and that same image is matching with the IVUS image also, that this is a good healthy landing zone, you can stop your pullback there. Simply you count the number of dots. This will give you the exact length. The angiographic measurement, if you some operators are comfortable just referring the angiographic image that I want to land my distal stage of edge of the stent. Suppose there is a D2, diagonal 2. From diagonal 2 to diagonal 1, they wanted to have a focal length. Then simply you park your transducer at the diagonal 2, start pull back till diagonal 1, and just measure the number of dots which are pulled out. that will be the exact focal length, and the same will be matching with your, if you are want to confirm it on IVUS, you can check with your long view also. The only thing is that when you do a manual pullback without connecting the MDU on the sled, you will not get the long view image. You will get only the cross-sectional image. The long view image comes only when you do a automatic pullback. Clear?
Okay.
So
Injection
basically,
tube with syringes.
without
Yes,
pullback
Vishal.
slate also you can acquire the image. The reason to just inform you that with sometimes it happens that some places the pullback slate is not available, so they feel handicapped that we cannot do the IVUS. It is not like that. You can still perform the IVUS. You can still assess the length also, and you can assess the diameters also on the cross section image. The length part can be assessed from this dotted dots which are there on the telescope.
Okay.
Yes.
To the catheter. Slowly flush the imaging catheter using the 3 cc syringe to purge the air.
And the reason to pull out this telescope before flushing the catheter is whatever the imaging window which is there, that should be emptied out completely. So just imagine if you are keeping the IVUS transducer along with the shaft in that imaging window and you are flushing, you will get a tremendous resistance flushing the catheter. And there could be bubble entrapment at that imaging window site. Imaging window means the transparent segment of the IVUS catheter
Refill the
towards
3
the
cc.
tip.
I'll just
Yeah.
try to show it. Yeah.
Yeah.
syringe using the 10 cc. Slowly flush the catheter a second time.
So here you can see the operator has done flushing twice with the 3 cc syringe. So the main reason behind it is the total volume of the catheter is 5 cc. And if you flush it twice with 3 cc, it will completely de-air the system and you will get a good quality image with no air bubble or no micro bubbles entrapment.
And refill the 3 cc syringe. Once complete, fully close the telescope by retracting the telescope to the hub. Connect the imaging catheter to the sterile bagged motor drive. Remove the seal on the bagged motor drive and insert the catheter until it audibly clicks into place. Once the imaging catheter is properly connected to the motor drive, the message "Catheter has been connected" will appear on the software monitor. Turn on the motor drive by pressing the imaging button to confirm the image on the screen. The automatic pullback sled is an optional accessory to be used with the MDU5 Plus motor drive to provide a long-view IVUS measurement. To attach the motor drive to the automatic pullback sled, place the heel of the bagged motor drive into the cup of the pullback sled. Use a rocking motion to roll the motor drive forward to snap into place. Press and hold the pullback release lever and then move the motor drive back and forth to ensure that it moves freely. Connect the imaging catheter to the sterile bagged motor drive. Remove the seal on the bagged motor drive and insert the catheter until it audibly clicks into place. Press and hold the pullback release lever and carefully move the motor drive.
So in this step also, see how the operator is moving the MDU forward by just holding the catheter a bit away so that it doesn't kink and it doesn't damages the catheter. Just repeat it.
Press and hold the pullback release lever and carefully move the motor drive to the forward position while supporting the catheter. Attach the telescope into the automatic pullback sled by clicking it into place. Press the reset button to ensure it reads 0.
Just pause there.
Yeah.
Where you see the.
Yes.
So next time whenever Dr. Kunal or Dr. Harshil, when you do the IVUS case, no, after the IVUS case, you just spend some time on this. So the display, what you see here, no, you reset it and you start the imaging and start pull back. The length what is displayed on this display will match with the number of dots which are pulled out from here at the red marker. So next time you just watch it. So if 3 dots are outside, you will see 30 mm of length here. Okay.
Okay.
So that level of precision is there. So when the moment you see a 30 mm length here, that means 3 dots are out of this red marker. Okay.
Mhm.
So you can
Yes.
still rely on these dots also for doing your measurement. So many Japanese operator, what they do after doing the first automatic pullback, they do the first pullback automatically, and then the second time whatever the analysis which they want to do, no, they just keep the imaging on. They insert the IVUS catheter, the telescope again inside, and they launch the transducer. Transducer is radio opaque. Okay, they bring the transducer at the distal landing zone as per the angiogram, reconfirms the image on the IVUS whether that is a healthy segment or not, and from there they start pulling the MDU by pressing this lever locking switch here. This lever locking switch they press and they start pulling the MDU back when it is connected on the sled. And the moment the transducer comes at the proximal landing zone as per the angiogram, they stop it there. They just see what is the length captured there. So you must have seen Japanese operator, they will not even ask a single thing to the paramedic that what is the diameter, what is the length. They will do it everything on their own. So in fact, the system is developed like that, that a operator can himself do everything on his own without asking anybody who is supporting on the machine side. Okay. So all those features are there provided in the system that you yourself can capture the length, what is the length coming as per the angiogram, and everything is possible.
Single operator,
Okay.
sir, how is that possible in a sterile field? Because you have a mouse, you have a keyboard, the monitor is so
Sorry.
far away. For a single operator, imagine
Uh-huh.
I myself is doing an IVUS at my own center. It is 12 in the midnight. Now
Uh-huh.
this entire setup of the sled I have, the transducer I have, and the processor I have, but
Yeah.
area
Yeah.
dot area, seeing the EL to EL, how can I do it? Do you have a touch screen which is
Yes.
a sterile?
No, no. So, yeah. So, Sushant, you have that image viewer screen on your
Yeah.
laptop.
Yeah.
Yeah, just share the So, are you now familiar what we have discussed on the MDU side?
Yes.
Yes.
So that will give you the length. Okay, that will give you the landing zone where you are getting a healthy zone. Now, on this cross-sectional view, can you see the dots?
Yes.
So each dot is 1 mm apart. Okay.
1 mm.
So
Agreed. Yes.
suppose now you are at this level. Okay. Now you have park your transducer at the distal landing zone as per the angiogram, and you confirm on the IVUS it's a healthy zone. There is no disease. Now just watch at the number of dots. You see
2 Savado max to max 2.2.
and 2. Okay, 2 or 2.25. One diameter is 2.25 and other one is 2. So we'll take it 2. Okay. So this is a 2 mm. Now you bring the pull the transducer back. So Sushant, you pull this axis. Yeah. So now just imagine you are pulling back the motor MDU, or the
Yeah,
automatic
on
pullback
my
is happening. Whatever you do automatically, you do manually, whatever way, the moment you come in the proximal landing zone and you feel that this is the zone where you want to land and it is healthy segment, you stop there and you again measure the dots on the screen. Suppose here, stop here. Now you see how many dots are there. 1, 2, and 0.5, so 3,
yeah,
approximately 3 or 2, 2.75. Okay.
correct.
So without even touching the machine, you can get the the basic information what operator needs as per the IVUS 1, 2, 3 discussions what we had. You need to know the distal landing zone, the diameter. You need to know the proximal landing zone diameter. You need to know the length between these two landing zones. You need to understand the plaque morphology, right?
Yes.
Yes.
So
Yes.
plaque morphology also you can assess just by a visualization. You need not to touch the machine, right?
Yes.
The
Diameter
only
and
job,
area.
yeah, the only job which a paramedic or a technician will do is to bring or move this cursor. Are you getting it? Move this
Yes.
cursor wherever you want to see, and wherever you want to put the measurement, he will just put the measurement there. Suppose you want to do a more precision work with the very precise measurement, then just bring it, stop it here, Sushant. Stop in a healthy segment, proximally, proximally, healthy segment, whichever segment you see. Yeah. And now put the measurement here. So he just need to identify the intima for identifying the lumen diameter and click done. It's so simple.
Okay.
Okay,
This is for
done.
lumen. This is for your
Vessel.
EL to EL vessel.
So now the question you must be having that why a vessel should be always EL to EL? Why not IEL to IEL? Right?
Yes.
Yes.
The reason behind that, when you compare EL with the next layer which it has, that is adventitia, against the contrast of adventitia, the hypoechoic layer or hypoechoic structure of the EL is very clearly visible. Sushan, just move this cursor to some other frame where they can see the EL properly.
Yeah.
Just move the cursor. Yeah. So stop here, stop
Yeah.
here.
Yeah.
Suppose here, now this is a very good picture to explain. Suppose if you are referring with the IEL to IEL, at some places the hypoechoic appearance of the plaque merges with the IEL, and you won't be able to see IEL very clearly, right? But EEL can be very clearly established in contrast to the outer adventitial layer. Clear?
Rochelle sir, can you just put a dot on the IEL, so that
So
we appreciate how an IEL looks?
So IEL nothing but the inner layer of the media which is in contact with the plaque.
So here you can see.
No, here you cannot differentiate IEL because there is some lipid-rich plaque which is getting merged with the IEL. Sushant, here
Yes.
the reason why I ask you to stop here, because this is the image which will not allow you to differentiate between IEL and the plaque. Are you getting
Right.
it?
Right.
Okay.
Right.
Because plaque is also appearing hypoechoic, no? The
Hypoechoic.
lipid-rich
Yes.
plaque is hypoechoic and media is also hypoechoic. But when you see the outer layer of the media, that is the external elastic lamina, in contrast with the adventitia, are you getting it? You are seeing the external circle in contrast with the adventitia, that is your IEL, and the inner layer of that media is the IEL. But many of the time the inner layer merge with the hypoechoic appearance of the plaque when it is a lipid-rich plaque or necrotic plaque. Am I clear?
Yes.
Yes.
That is the reason why the vessel is always measured from EEL to EEL. Am I clear?
Got it.
Okay.
Yes.
So vessel is nothing but EEL to EEL and lumen is nothing but intima to intima. And between intima and IEL, the plaque deposition happens. Okay.
Okay. Rochelle
So
sir,
I think, yeah.
one more thing. When you give us the CD of IVUS, okay,
Mm-hmm.
and then when we put it in a DICOM reader, and when we
Yeah.
want to export the image as seen as live IVUS, at what frame rates we should export it? FPS. They given an option of exporting because these are all frames, right? 1 to
Yeah.
2000. So there has
Yes.
to be some significant frame rate which replicates the frame rate of a live IVUS, no? If I
Yeah.
export it at 1000 frames, then it will be like an accelerated IVUS. And if I do it at 100, it will be like a slow pullback. So what
Yes.
frame rate is the appropriate?
So usually, see, when we do the IVUS pullback, no, so 30 frames of the cross section captured per second. Okay, at the 0.5 mm pullback speed. So the
So
lower
30
the frame
FPS.
rates, 30 frames per second would be the ideal if you are
Oh,
transferring it to, yeah.
yeah, you're converting into a MP4 or an AVI, you have to set
Mm-hmm.
a frame. So that is
Yes,
30
yes,
FPS.
yes.
Yeah.
30 or 50 also you can do it. 50 also okay.
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 Because that's important when you're trying to present a paper or something, no?
Yeah,
It
yeah.
should be
So
appropriate.
have you all got this image viewer software with you on your Windows laptop?
No, we don't have.
So, Sushant, I suggest next time whenever you
Yes.
go to Hinduja, no, please see to that all Dr. Harsh, because that is very much needed during our next level of discussions. Because if they won't be able to access all these things on their laptop, no, then it will be difficult for them to understand the things. Okay.
Right.
So I hope all of
I'll
you
make
have
arrangements for that.
you all have the Windows laptop, right?
Yes.
I don't, but I'll manage someone.
Okay. Because this software or the IVUS system is only Windows based. So everything what we can do offline is a Windows based system. Like this software is also DICOM viewer is also Windows based software. So
Okay.
it is compatible only on Windows.
Okay.
Okay.
Sure. Yeah.
So thanks for all your
So,
time and
So just one doubt, sir. So one doubt.
yeah.
EL to EL area will be vessel area, right?
Yes, EL to
Yes.
EL will be vessel area.
And lumen area will be what? Lumen area,
Intima to intima.
intima to intima. And the plaque area we calculate as EL area minus intimal area.
Sorry, come again.
So how do we calculate plaque burden? Plaque burden.
Yeah,
Yeah,
correct. That
plaque
is the
burden
way.
will be just Sushan, do it at this frame. So
Yeah.
plaque burden will be corresponding to the particular cross section. Okay. Suppose this frame number 1844 at 1844 frame number, if vessel is 12.43 square mm, okay, and lumen is 4.29 square mm. So at this
Mhm.
level, we take vessel as 100%. Okay, out of 100%, 65% is a plaque.
Okay.
So leftover, yeah, so leftover 35% is your lumen available, right?
So basically you have done vessel area minus lumen area, right?
Yes.
Yes.
Okay.
It is a percentage calculation. Like if vessel is 100%, out of 100%, 65% is a plaque, then 35% is a lumen available. And even if you compare, you do the percentage calculation, 12.43 is 100%, then 4.29 would be 35% of that,
Uh, less than 50%. Okay.
right?
Okay. Okay. Okay.
So as
So
we
it,
progress in our discussions, no, on more advanced level, so we have just started with the basics of discussion. As we move into the more advanced level discussion on algorithms, measurements, everything, we will get into all these discussions on measurement
All right.
side. Okay.
Okay. Okay.
So hope
so
hmm.
yes, we shall continue.
So hope we address all your queries with regard to this particular presentation. I'm not asking about, like, there are many things which we will go cover in the subsequent sessions, but whatever discuss in this session, I hope you're clear with those things.
Yes, sir. Yes. Yes.
Okay. Over to you, Sushant.
Yes, Kunal sir and Harshil sir, in next session, I'll try and explain you all the tools which we can use in the iOS system as well as in your laptop in this image viewer. 90% of the things are similar. There are a few tweakings which I'll try and explain. And apart from that, there is a next presentation on image interpretation, basics of image interpretations or a grayscale image, how it looks, how you can identify intima, media, and adventitia, and how three basic plaque morphologies which you can identify in IVUS. So in next session, we can do that. So I just wanted to ask you, so when should we conduct the next session? Is Monday fine? Because as Vrushal sir has given you certain reading materials, I want you to go through it during the weekend if you get
Yeah,
any
we'll
time.
go through, but Monday will be difficult because Monday
Okay,
is usually the heaviest day of the week.
correct.
So I think in the second half of the week will be better. Maybe Friday or Saturday.
Fine, then next Friday if we can meet because uh, Vrushal, do you have any inputs on that?
No, so apart from the day, what time slot is convenient for you? Like even like if it is a Tuesday, Wednesday, if any particular time slot, maybe a 1 hour time slot, which is convenient, we can then block it at our end also, so that we will not have any other commitment during that time,
Correct.
and we'll finish off with that like that. If you can propose us those, no, so you just share 2, 3 particular slots during the next week. We will try to see that if everybody is there, nothing like it. Otherwise, we can always have the next slot for the discussion.
Sure, sure. We'll discuss it on WhatsApp. No problem. We'll let you know.
Okay. Yeah.
Yeah, sure.
So, and
Next
if
week. Yeah.
possible, please share the recording. No, very
Yes,
important for revision. Very important.
yes.
Okay. Yeah.
Okay,
Thanks.
fine.
Thanks, everyone.
Thanks everyone.
Okay.
Thank
Bye.
you so
Thank
much.
you.
Have a
Thank you.
nice
Great
day.
session. Great session, sir.
Yes.
Thank you.